So we'll start out first with the surgeon's perspective. Dr. Fakhry.
Good morning. Ben, thanks very much, and I appreciate the invitation. And John, I appreciate all the help in getting me here and making sure I figured out how to put all the pieces together. It's a pleasure to be speaking at your conference. I've already learned more this morning about interventional radiology than I've learned in the past several years of actual practice, so maybe I should come here more often. What I'll try to do today is just run through some of the things that I think the trauma surgeons of the world, at least the world I'm living in currently, think about when we're dealing with the various problems of abdominal bleeding and how we would expect to interface with the interventional radiology community. And then Howard will give you the perspective on the specifics of the interventional technique. So if you've not seen our new building at MUSC, I don't get to work there. I'm still in the old building because we don't get promoted because, you know, trauma is sort of still the redheaded stepchild. And I'm working on the plan for the institute. Right now I've got this stick drawing. I do have good people though, and at the end of the day, one of the things I really have enjoyed about my interaction with the interventional radiology folks is, you know when you're in trouble, who's going to be there with you, and you know who shows up at night, and you know who comes in on the weekends, and it's pretty clear. And so it's been a pleasure working with a very, very competent group. We became, this is just a little bit of showing off, I apologize. It's our national trauma center verification at MUSC. We became South Carolina's first level 1. 2 other hospitals have now followed, and I'm happy to report that in the next couple of months, the American College of Surgeons is coming to do a statewide trauma center consultation, trauma system consultation, which actually means we're paying more attention to the injured patients. So that's just one of the things that we've been working on that matters a lot. I always take the opportunity whenever you give me a microphone to tell you about what I do and why I think it's useful. I'm particularly interested in the trends that I've seen around the world because I like to travel, and I'd like to know that if I get injured somewhere, it looks like I probably should go to Australia. They have a good system. There's some places I don't want to go because of these numbers. 1.2 million people per year are dying of just road traffic crashes. That's over 3,000 a day, with almost all of them at low and middle income countries. These are all the non-Western, non-rich countries of the world at fairly high cost. And most interestingly, the prediction by the experts at WHO and other places is that injury will become the 3rd biggest contributor to the global burden of disease in 2020. So that guarantees me both a job and the opportunity to travel, which I like. And so if you read The Economist, which refers to itself, by the way, as a newspaper, you realize there's a very interesting trend going on. Injury, road traffic crashes are dramatically down in the Western rich world, but they're climbing astronomically fast in the developing world. And that's because we're helping them build roads, we're giving them cars, but look, we don't give them sidewalks, we don't give them trauma systems, we don't do a lot of the other things that we've developed and figured out. So you're seeing malaria and TB disappear from the developing world. It's being replaced essentially by road traffic crashes. So careful where you travel, make sure you know where a good trauma center is and all that. And WHO has made this the decade of action for road safety. If you're interested, there's a lot of fascinating things that people are doing around the world to keep people safer. In the United States, you know, we lost over 180,000, it's 181,000 people last year to injury, leading cause of death up to the age of 45, and 4th leading cause of death overall. Remains a substantial problem, but it's really fascinating to see the demographics change, and this is a slide that I like to show because it really has changed in my career over 24 years. This has almost been flipped. So in homicides, we've got about 16,000 homicides in the United States right now, and for the first time, since I probably can remember, it's not in the top 15 causes of death at the CDC. That's unique. That's never happened in America. So whereas some people think there's more violence in America, there may be more dramatic cases of violence, but the numbers are the lowest they've ever been in our lifetimes. But look what's replacing it. It's suicide. And firearms play a role in both of them. And even more scary is the drug poisonings. With half the drug poisonings, 16,000 people, the same number as homicides, being due to drug overdoses with narcotics that you purchase with a prescription. That is becoming as bad as being shot to death. Car crashes, like I mentioned, are decreasing dramatically all over the Western world. For most of my career, about 42,000 people a year died of car crashes in America. And last couple of years, it's been down closer to 32 or 33,000. And many people have attributed that to economy, cost of gas, but there's lots more things like better cars, safer cars, less driving under the influence, and maybe a bit of better trauma systems. And I like to think of these as crashes, not accidents, and I show videos like this. You might have to click that for me because it didn't run. And on the news, somebody is going to say, you know, this poor child had an accident. Well, you know, he's up on the roof, he's wearing inline skates, and now he's going to try to come down. And if I can get it to run, we'll see it run. If it doesn't, that's okay. We can, unless you want to run it outside the application. And so calling them accidents just perpetuates the notion that they're not preventable. Or we can go to the next one if it doesn't work. So you're always supposed to prepare a story to tell in case this happens. Oh, there we go. So we'll run this in the actual movie. And so he's going to have that pelvic fracture that's going to have that bleeder that we're going to send to be embolized in radiology. But this is by no means an accident. This was not an act of God. This was not coincidence. This didn't just happen to this poor person. And if you look at the next one, thank you for your technical help. So this is a fellow who is going to do something that's going to get called an accident. He's going to run a red light by going around another car, which it seems excessive to me. I don't know about you, but how does this get called an accident, an act of God, or a coincidence? This is a statistical probability. In my opinion, it's an act of attempted murder. And we can't convince our media to stop calling them accidents. So we've got some work to do there. I promise to not show more gory videos after this. There are a lot of them if you're interested. I'm happy to share. Well, let me get to the subject I was actually assigned. So abdominal injuries is the area that I'll focus on, and I'm going to talk predominantly about splenic injury. But just to give you some of the background that concerns us from the perspective of trauma surgeons, very common injury still, can be lethal. We're still having people die of ruptured spleens in America. And it's a scary thought, but that is actually happening. One of the reasons is because you can't tell from the outside what's going on the inside. And in our world, of course, there's blunt and penetrating trauma that we have to deal with. They're really rather different disorders and problems. And so I may need your help advancing this because I'm having, there we go. In the blunt world, it's liver, spleen, and kidney, the solid organs. In the penetrating world, it's the hollow viscous that's the issue. And those are different enough. I can tell you that when I first started my training in Chapel Hill in the 80s, if you had an abdominal injury and had either peritonitis or a positive diagnostic peritoneal lavage, which many people did, we ran you off to the operating room, and we didn't need a CT scan. We didn't have a CT scan. We also didn't need it because we saw everything live and in color. Diagnostic peritoneal lavage, as you may know, has now almost disappeared. I have to show this slide to the residents because nobody knows what it is. Basically, you put a catheter in the abdomen near the belly button, you put some saline in there, and you see if there's any blood. We hardly ever do that anymore. So we don't operate much anymore. And so the opportunity to detect some of these injuries and be very specific about what we're dealing with has gone away. That's really because we rely almost completely on CT scanning in the blunt trauma patient these days. And I think that's a good thing because now we know what's bleeding. We used to know that there was bleeding, we didn't know what it was and had to operate, and we didn't know if it had stopped or not. So it started with the experience in children, by the way, in case you're wondering. The folks at Children's in Toronto were probably the first to do this, where they watched kids bleed from their spleens and watched them and gave them blood, and eventually it stopped. In some cases, they gave them twice their blood volume and blood transfusion. 80 per kilo. That's rather dramatic. But those kids needed their spleens, and so I think it was an advance. And nowadays, for us, non-operative management of splenic injury and liver injuries and kidney injuries is the standard of care. And I think you'll find that at almost any trauma center you go to. The drivers of this is the fact that we have ubiquitous CT scan technology. I never get a patient, even from referrals from small hospitals, without an extensive CT scan workup. And now we're doing pan scans, as you know. So, and the other reason that all of this works is bleeding stops most of the time. And surgeons are fond of saying that it stops eventually. It's just a matter of when and where. So with those two things, we now can tell what's exactly bleeding, and the fact that most bleeding will stop one way or the other. We've got some room. By the way, the first surgical publications that allowed us to test the concept in adults was by Tony Meyer, who's the chair at UNC now. And look at that date, it's 1985, so it's not that long ago. And I remember the first time I did one of those, watching the spleen bleed until it stopped. I sat by the patient, Mark was in our burn unit, in the old burn unit, and I sat by the patient for the entire night because I didn't believe that the spleen could be salvaged, because I was convinced it had to come out. So old habits die hard. It does work, though. It's actually spectacularly successful, shortens length of stay, decreases blood transfusion. Basically, that means when we operate, we actually stir up the bleeding, we cause more bleeding. It's pretty clear. Whereas if we leave them alone, the majority will stop on their own. They get better quicker, they have less morbidity, and they don't, of course, get into trouble with overwhelming post-splenectomy sepsis because they have their spleen. Of course, there are other benefits. It's not for everybody and it's not for everywhere. It does require that you have very high-level care available, and really the key thing is a surgeon, and in these days an interventional radiologist, who is readily available. Readily available means very, very soon after you decide you need to go. So if that's not something that can be done within the hour, it probably shouldn't be tried. So the current status quo for us is that we are doing almost exclusively non-operative management as the first step. Almost every single person gets a CT scan. My standing joke is, if you're in our emergency department, if you're a visitor, there's about a 5% chance you're going to get a CT scan. And you just have to be real careful what room you wander into. We are doing many, many fewer operations for solid organ injury or trauma in general. The residents are really not well enough trained in many places that don't have big trauma volumes, because there's just so few operations. And we're doing less laparotomies that don't result in a surgical intervention, so that's a good thing. We are missing hollow viscous injuries, and that's something that I'll talk to you a little bit about later on. And it prompted me to do some work that started with this publication back in the year 2000, and then which showed that basically we're missing small bowel injuries and they're causing people to die. And we did a large multi-center trial as a result of about 250,000 patients that showed that that's a real problem, and that if you delay more than 24 hours, people die. So there are some consequences to the non-operative management approach, and that's predominantly because CT doesn't pick them up. Blunt trauma right now is our bigger problem. As violence in America has decreased, we are seeing so few that in some cases people have to travel somewhere to get their trauma rotation to do some penetrating cases. You know, we're reliant on the triage of patients in the field, and I'm sure you're all aware that we use a very, very successful program that's now all over the world called the Advanced Trauma Life Support Course. We follow the airway breathing circulation paradigm. When I was in Germany and in France, and I went and visited some colleagues there, they did ATLS just like we do it. And I thought that was remarkable that we've disseminated this. Now it's getting into the third world or the underdeveloped world. I think we're seeing huge progress with that. Penetrating injury is much simpler in many ways. It's a connect the dots kind of approach. Basically, if you have a gunshot wound to the abdomen, or you have a stab wound to the abdomen and you're hemodynamically unstable, have peritoneal signs, or if you have a gunshot wound, we're going to take you to the operating room because the incidence of meaningful injury in those settings is so high. There are a few patients with stab wounds. Actually, there's quite a few patients with stab wounds. If they're stable, don't have peritonitis, we can watch them, do a wound exploration. And there's occasionally a gunshot wound patient that does not need surgery if it's a tangential injury or sometimes an injury to the liver detected by CT. But for the most part, gunshot wounds go to the OR right away. Stab wounds go to the OR if they're unstable, have peritonitis, or we can find a hole that goes all the way. For the blunt trauma patient, the paradigm that's now, I think, most commonly applied in the trauma world, the stable patients are the ones, of course, that are best candidates for non-operative management. However, there are some unstable patients that can become stable with the infusion of volume and some other interventions. We're becoming braver, I guess, in terms of not operating right away. It's either braver or less brave, depending on your perspective. The ones that we still take directly to the OR are a smaller group now, probably less than 20% of the serious splenic ruptures and liver injuries are going to the operating room directly. More and more. In spleens, it's probably 80%. In livers, it's less than 5% that go to the OR, by the way. We hardly ever take a big bleeding liver to the OR anymore. And we still take some spleens. So things have changed a lot, and as long as we can, relatively speaking, stabilize a patient, then we're going to try non-operative management. We never use DPL anymore. None of the residents knows what it means, and none of the nurses knows where to find the stuff for it. It's sort of an historic thing. We're using a lot of abdominal ultrasound at the outset to help us determine what's going on, but there's no question that CT scan is really where we get our information and do our planning. And as you heard, there's a lot of useful information to localize bleeding, identify sources, etc. One thing that we're very committed to is grading the injury on the CT scan, and so there's a scale that we use. We don't use oral contrast for trauma scans anymore, and like I said, you will miss hollow viscous injuries and ruptured diaphragms at least 15 to 20% of the time. This is the scale we use, and we try to encourage our radiology colleagues to help us grade these in their reporting, because for reviews, for research, for quality evaluations, it's really useful to have a standardized way of describing injuries. A case in point, this is a pediatric case, a sled crash in a 6-year-old with a grade 4 splenic rupture, also had a renal artery injury, as you can see there, and was managed non-operatively, despite the fact that, look at all this blood in the paracolic gutters and all this blood down in the pelvis. And now, I can tell you when I started my training, that patient would have been in the operating room as soon as they arrived. The spleen would have been out, and we'd have been, celebrating probably the wrong thing. Because nowadays, this patient is saved. Their spleen stays in. And in the pediatric age group, removing a spleen for trauma is considered a PI event to be reviewed. It's so uncommon. In the adult world, a little bit more common. But again, it's a big, big shift in our approach. So the approach for us is if they're unstable with intra-abdominal injury evident, they go straight to the OR. If they're stable, they go to CT. If there's no blush on the CT, we would consider them ideal candidates for non-operative management, and usually put them in the ICU for at least an overnight visit, especially for the spleens. We're less worried about livers. If there's a blush, we'll refer them over to our interventional radiology colleagues, and we'll hear more about the specifics of that. The success rates of non-operative management have continuously increased over the decades, in the last 3 decades. Livers do much better than spleens in general, and the grade has a lot to do with what's going on, but most importantly, it's a combination of grade and hemoperitoneum. And that came from this study we did. There were 27 trauma centers that got together, and we all collected our data, had 1,488 patients. We found that a third or so of patients who came in with major splenic injury went to the operating room directly because they were either unstable or had some other finding, sometimes distension, peritonitis. But about 2/3 of the patients were admitted for planned non-operative management. Ultimately, 10% of them failed. So if you'd like a big number, a large series with a big number, and say, what's the failure rate of non-operative management in splenic injury? It's probably about 10%. And the way we figured out that the grade was important is when we graded them, you can see that the failure rate of non-operative management increases dramatically by grade. So it is useful prognostically as well. If you also looked at the amount of hemoperitoneum, if they had a lot of if they had a little bit of hemoperitoneum, described as what's around the spleen only, high success rate, a lot of hemoperitoneum, which is blood all the way into the pelvis, much lower rates of success, and moderate, which is in the paracolic gutter, medium rate of success. So if you put the two together, grade and hemoperitoneum, you'll see that you've got, even within a grade, hemoperitoneum is responsible for worst outcomes, or associated with worst outcomes in every grade. So it's not just how the spleen looks, it's how much blood there is in there, and that's because shock matters. And that study also showed that most of the bleeding, the failures of non-op management are occurring in the first day or two. The longest case was the case I had. It was 30 days out. He was coming back for his follow-up CT scan to the clinic, and he bled downstairs in the registration area. So we just rolled him up to the operating room. But that rarely happens, as you can see. Almost all the bleeding is going to happen in the first few days, and that's why we keep them in the hospital for those first few days. Here at MUSC now, this is what we're doing, and that's consistent with what I've told you. We basically operate on the unstables. We will occasionally take a quasi-unstable patient and try to get something done. But that's not a good idea. Usually you get into trouble. It's the more or less stable patient with a blush that ends up with angiography. We still have a lot of trouble with what to do with them afterwards. Do you get a CT scan? When do you get it? The consensus is approximately 2 months, but when we did a review, one of my fellows and I did a review of all the trauma surgeons that would answer a survey, and we had answers all over the place about when should you let them get back to work, what kind of follow-up do they need. It was scattered. And actually, surprisingly, in that study, 20% of the centers said they rarely use angiography for splenic injury. And this was not that long ago. So I'd say there's still a fair amount of controversy as to the role of everything. And we've also discovered over the years that seniors develop special attention, and we know that the failure rate of non-operative management is multiple times higher in the older patient group than it is in the younger patient group. And that we saw that also in that large multi-center study that I described to you. We extended it and looked at failure rates and mortality rates are both higher as you get older. Once you get past 55, I was sorry to hear that because I just crossed that threshold. Not only are mortality rates higher, but failure rates are higher. And when they fail, they have an even higher mortality. So being older and getting non-operative management is messier. And in many cases, people will just take the spleen out of an older person rather than take the chances with having cardiac ischemia from prolonged shock, etc. And you can see even by grade, the patients have more trouble if they're older. So all those things have caused us to think very carefully about the older patient and how aggressive we want to be with preserving them. For livers, we did this when I was at Fairfax, and for livers, I can tell you, if we see a grade 1 or 2 liver, we don't even put them in the ICU. We hardly do anything for them. Grade 1 and 2, one day will be going home from the emergency department, I suspect. Grade 3 has a moderate chance of bleeding and having complications. Once you get to grade 4, though, those are the ones that we worry about. Not a lot of them, by the way. And so that's something to keep in mind. The approach to livers is almost identical to the approach to spleens, except that we're much less worried about them. Their rebleed rates are much lower, and if they get complications, they tend to be long-term ones like pseudoaneurysms in grade 4. So the challenges that remain for us now are the complications of non-operative management, which still happen, although they're not frequent. The missed hollow viscous injuries. We don't know yet when we should let, when a mother asks me if her son can return to being a linebacker on a football team, I'm not sure I know when to let them back. I'll usually wait 2 to 3 months and get a CT scan before I release somebody to that level of contact sports. Of course, we're not getting enough operations to keep us happy as surgeons, so we're trying to find other things to do. And I'll leave this for the next presentation. We think from where we sit, we've seen a lot of variation in approach, both by institution and occasionally by practitioner. So I'd be curious to see what your group thinks of what we're doing. Here's some of the complications of non-operative management. And one of my sort of personal interests is, what does a subcapsular hematoma do a few days out or a month or so out? And I can tell you, here's one thing it does. It ruptures. So this is a patient we took to the operating room. Forgive the bad picture. This is when I had a cheap phone before I bought an iPhone. So this is the subcapsular hematoma. On the other side of it was this. This patient bled out 4 or 5 days after his initial injury. So subcapsular hematoma is still a problem. And I pointed out to you, we're still struggling with this problem of missed hollow viscous injury. So we conducted a fairly large trial, as I mentioned, and we found that everybody relied on CT. We had a fair number of deaths that were attributed solely to the missed bowel injury. And then when we went back and did an even larger study, we found that hollow viscous injury, although rare, was associated with mortality when you waited longer than 24 hours to pick it up. And importantly, 15% of these patients were missed on initial abdominal CT scan, even with oral contrast. So we know that there's a miss rate for hollow viscous injury, and that's become the new bugaboo for the trauma population managed non-operatively. So I'd like to conclude by saying that we still see a fair amount of blunt or solid organ injury in the abdomen with a lot of bleeding, and some of those people will die. We are almost universally reliant on CT scan for the diagnosis. I think some of my residents would not know what to do if there was no CT scanner. That's why I show them the picture of the DPL every now and then. Vast majority of the time, non-operative management works really well, and that can be supplemented with angioembolization for the stable patient with a blush. We're still, I think, in a stage of asking the question of what is the role of angioembolization in patients without a blush, and even what is it in the occasional patient who's unstable-ish, but not real unstable. If you know, I'm not sure how to define that properly for you, but some of my colleagues have figured out a way to define that. I'm not there yet. So this is what I had for you this morning, and I once again appreciate the opportunity very much to present this information. I hope it gives you a background for how the trauma surgeons are thinking. And that boat, by the way, is a Beneteau. It's made here in South Carolina, and it's not my boat. Somebody asked. It's the boat I'd like to have, or I'd like one of you to have and invite me to. Thank you very much.